Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Bloomberg School of Public Health. Today's experts will discuss evolving forms of COVID-19 vaccines and what the future might hold for their use. They will provide updates on the latest FDA recommendations for updating and administering COVID-19 vaccines, potentially once a year. They will discuss potential new vaccine delivery platforms, such as nasal sprays and drinkable liquids. First, I'd like to briefly introduce our speakers. Dr. William Moss is a professor in the departments of epidemiology, international health, and molecular microbiology and immunology at the Johns Hopkins Bloomberg School of Public Health. He is also director at the Bloomberg School's International Vaccine Access Center. His broad research interests are the epidemiology and control of childhood infections in resource-poor countries, particularly measles, malaria, and pediatric HIV infection. Dr. Rupali Lume is an associate professor in the departments of international health, epidemiology, and health behavior and society. She is also deputy director of the Bloomberg School's International Vaccine Access Center, an expert in vaccine behavior and decision-making, including vaccine hesitancy and acceptance. She studies how health information can best be communicated to individuals in different contexts and through different channels. We will have time for questions following our speakers' remarks, and the procedure will be as follows. We will take some questions that have been submitted in advance of the briefing and some from the Zoom chat. If you have a question during the briefing, please enter it in the Zoom chat addressed to all panelists. Please enter your name, media outlet, and question, and we hope to cover as many as possible. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. Participants will be muted during this briefing, and it will be recorded. Dr. Moss, please go ahead.
Thank you very much, Ellen. And, we all know that the pandemic is far from over. Here in the United States, there are more than 2,000 deaths per week and 20 to 30,000 people hospitalized at any time. But I think it's important for us to reflect upon the remarkable progress that has been made in developing COVID-19 vaccines in record time, just about a year from the start of the pandemic to when vaccines became available to people, and also in conducting one of the largest global mass vaccination campaigns ever. In the past 3 years, almost 3/4 of the world's population has received one dose, at least one dose, of a COVID-19 vaccine. That's about 5.5 billion people, and more than 13 billion doses have been administered. However, we continue to learn more about vaccine effectiveness across age groups and against more recent SARS-CoV-2 variants, as well as the nature of hybrid immunity, that is immunity resulting from both natural infection and vaccines. Although the story is complex, vaccine effectiveness remains high against moderate and severe disease, which is critically important in preventing hospitalizations and deaths, but not as high as was seen in the original clinical trials that led to the emergency use authorization of these vaccines. And we know that vaccine protection wanes over time, and particularly rapidly for mild and moderate disease, and certainly for infection. Going forward, I know there's a lot of uncertainty, but I think there are some things we know. We know the SARS-CoV-2 virus will continue to mutate, as viruses do. But we'll yet to see whether a new variant emerges that can really escape immunity and that is highly transmissible. We know that a large proportion, most people have some immunity against this virus as a consequence of vaccination, infection, or in many people as a hybrid of both. We know that vaccines will continue to protect against severe disease and death, but that antibody levels will wane, and that these vaccines will not protect against infection and stop transmission, at least our current vaccines. Our goal should be protection against severe disease, hospitalization, and death. That's our primary objective with vaccines. We know that older adults and those who are immunocompromised will remain most vulnerable and should be the focus of our vaccination efforts. What booster doses will look like going forward is still uncertain, and my colleague Rupali Lemay will speak more about this. But one possibility is that we'll see annual booster doses given, certainly to those who are most vulnerable, and perhaps in conjunction with influenza vaccines. But we also know that the demand for vaccines has decreased, and only 16% of the eligible population here in the United States has received the updated bivalent booster dose. We also know that there are many vaccines still in development, hundreds in fact, and many of these vaccines, unfortunately, will not make it into the market, but there are some that I think I'm particularly excited about. Those include the nasal vaccines. These will induce immunity in the mucosa of the nasopharynx, the site of initial viral replication, and may prevent infection and reduce transmission. So these are something to watch for. In addition, we may see more vaccines that target an increasing number of variants and perhaps some conserved regions of the SARS-CoV-2 virus so that we won't have to update our vaccines as frequently as new variants emerge. And I'll just say that many of these developments for COVID-19 vaccines will also have spin-offs for other vaccines for children and for adults. And so I think we're entering an age of a very exciting age for vaccinology.
Thank you, Dr. Moss. Now we will hear from Dr. Lemay. Dr. Lemay, please go ahead.
Thank you so much. I have really 5 key points that I would like to make. The first really focuses on where are we in the COVID-19 pandemic, and it's not over. COVID-19 is going to be here. We're going to have to learn to live with it. There are steps that we can take to really reduce risk of infection and prevent long COVID. So 3 years into the pandemic, approximately 19% of the US population has not received even a single COVID vaccine. There are many reasons why individuals have not accepted COVID-19 vaccines. A key reason is that many people think that COVID is not severe enough to warrant a response, i.e. getting a vaccine. However, what we do know is that long COVID has many detrimental effects. These include health, emotional, and social effects that can last for years. Another key reason is that people do not believe perhaps the vaccine is effective. And as Dr. Moss just mentioned, all of the COVID-19 vaccines that are available in the US greatly reduce severity related to COVID disease. My second point is that those between the ages of 18 and 24 are the least likely to be vaccinated against COVID-19. As a result, it's very important to think about how we can reach young people that they will accept a COVID-19 vaccine because they are still susceptible to COVID, including long COVID. This includes, for example, using unique messengers that hold the trust of young people. So perhaps thinking about messengers outside of the healthcare system, such as artists, for example, community leaders, and faith-based leaders may actually be the key in persuading young people to accept COVID-19 vaccines. The third point that we're seeing is that those that lead more Republican from a political orientation or political ideology are less likely to be vaccinated than those that lead Democratic. This discrepancy is really due to a politicization that has happened of COVID-19 vaccines. This politicization has also led to massive misinformation related to not only COVID-19 vaccines, but COVID in general. The fourth point focuses on equity. Amongst those that are non-insured, almost 27% are unvaccinated. And we compare those to those that are insured, only 11% are unvaccinated. These disparities can really be narrowed if more individuals are able to obtain health insurance. Due to the Affordable Care Act and other recent legislation that has passed, even after the federal supply of vaccines is done, the majority of people will be able to get a vaccine free of charge. However, costs may become a barrier for those that are uninsured or are underinsured once the federally purchased doses are no longer available. The last point I'd like to make is that scientists are very much split on this idea that was discussed at the US FDA in its proposal to update COVID-19 vaccines once a year, similar to the approach that they're using with regards to updating influenza vaccines. While this approach may make it easier for individuals to remember to get an annual vaccine, there are concerns related to duration of protection as well as timing. One reason is that we understand the seasonality of flu and know exactly when to vaccinate for an optimal effect related to protection against influenza. But we do not know whether or not people need to be vaccinated every year or less frequently to be protected from severe COVID. A second reason is that SARS-CoV-2 variants don't sweep the world as uniformly as influenza does. And as a result, it will be quite difficult to coordinate the composition of such a large delivery of an annual COVID booster globally. Thank you.
Thank you, Dr. LeMay. Now we will take questions. If you have a question, please enter it in the Zoom chat with your name, media outlet question, and to whom you'd like to address your question. Here's the first question from freelance WebMD reporter Nick Tate for Dr. Moss. How strong is the evidence that COVID vaccines boosters can reduce risks or severity of long COVID?
Yes, Ellen, this is a very important question. And there have been more than a dozen studies looking at the impact of vaccination on long COVID. And I think, including several systematic reviews. And I think the take-home message is that COVID-19 vaccines do reduce the risk of long COVID, but only at a, I'll say, marginal impact. They don't completely prevent long COVID from developing. And one way of thinking about this is that we know that long COVID can develop even after mild COVID disease, and the vaccines work best at preventing severe disease. So COVID-19 vaccines will reduce the risk of long COVID, but at a relatively marginal level, and will not provide complete protection against long COVID.
Thank you, Dr. Moss. Here are questions from Alex Maturshaw at Nexstar Digital. For Dr. LeMay first. As we started to see breakthrough infections, there was some talk of annual COVID vaccines, much like we do with the flu. Where are we on that?
It's a great question. As I mentioned, this was a proposal that was debated by many scientists at the FDA, and I think there is sort of non-consensus with regards to how to move forward on this. As I just mentioned, the reason why there is a little bit of a discussion and not yet quite clear in terms of how to do this is that while we know how influenza essentially patterns over a seasonal pattern, we know that individuals are more susceptible, we know that it spreads from the fall to early winter months, we don't know as much about COVID. So that's the first piece. The second piece would be, even though, let's say we focus on doing an annual campaign here in the United States, right around the same time we do an influenza campaign, we would have to also coordinate this at the global level, because as you all know, diseases don't really respect borders. That is a larger sort of logistical issue, I think, that would have to be considered. So I think there is still much to be discussed, and there has not been an agreement yet on how to move this forward. It's just one option on the table of having this annual COVID shot along with your influenza vaccine.
Thank you, Dr. LeMay, and one for you, Dr. Moss, also from Alex. Do you think we'll see annual COVID vaccines based on immunity waning over time, or is it more about tailoring vaccines to potentially new variants that would arise?
Yes, that's an important question, and it's probably a combination of things that will drive recommendations on booster doses, including, as Dr. LeMay mentioned, considerations at least of some simplicity in the guidelines. So I think it certainly will be driven by new variants. If we see new variants that really escape existing immunity, it will be driven as well by waning immunity. We know that certainly antibody levels wane and protection against mild to moderate disease wanes. We have seen fairly sustained protection against severe disease. It's also going to be a function of the population. And as we've mentioned, older adults and those who are immunocompromised are most vulnerable. And so there will be this kind of just trade-off in the recommendations between targeting specific subgroups like older adults and those who are immunocompromised who may need more frequent booster doses, compared to healthy young adults who may require less frequent booster dosing.
Thank you. Here's a question from Arthur Allen at Kaiser Health News for Dr. Moss. While the protective effect of the initial vaccination series has been obvious and boosters also appear to significantly reduce serious outcomes in vulnerable groups, what evidence is there that repeated boosters protect against serious outcomes in populations that are younger who don't have medical vulnerabilities, especially when nearly everyone has had COVID once or more already?
Yes, this is an important question and relates to my prior point around what recommendations on booster dosing may be, and we may need recommendations that are different for young, healthy people compared to older adults and those who are immunocompromised. There is some evidence, so there have been some studies that do suggest an added protective benefit against both symptomatic disease and hospitalizations in younger people with a booster dose. It's less clear whether there's an increased benefit from the bivalent booster compared to the original monovalent booster, at least in immunogenicity studies that look at antibody responses. But I think this will be a really important consideration as the CDC and FDA go forward with their recommendations in weighing the trade-offs between recommending around booster doses for young, healthy people. So I would say there's some suggestive evidence of a benefit that's rather short-lived, but that'll be part of the trade-off.
Great, thank you. Another one from Arthur for Dr. Lemay. If COVID in its endemic stage does start to resemble other coronaviruses and repeated infections are likely, how can we be sure that it's good public policy to urge everyone to get vaccinated every year?
It's a really good question. And I always think about vaccines as one tool in our public health sort of toolbox, if you will, right? It's one way to really reduce your risk of severe infection. And as Dr. Moss mentioned, the vaccines, the way that they were created, they were really to reduce severity of the infection. And so for me, I think it is very much a calculated case-by-case basis with regards to whether or not someone should be getting an annual COVID shot. I think it's the same argument that we see for influenza. I think many people that I speak to get all other vaccines except for influenza vaccines because they do not think that they're protective enough for them to take it. I think for COVID, I think the difference is for COVID, we are just learning, I think, more and more about long COVID and the effects of long COVID. And we know that multiple reinfections increase your risk for long COVID. And so I still would suggest that with regards to protection and thinking about your longer term health, it's still going to be important for individuals to get the vaccine, again, if there's no contraindications, but to really reduce that risk of reinfection and reduce the risk of long COVID would be my suggestion.
Great, thank you. Here's a question from Ethan Snyder at Trends in Medicine for Dr. Moss. They say the vaccine reduces severity, but does it still reduce the spread and risk of infection? Would it be worth it for a young adult male to get a vaccine even though he already has natural immunity?
Yeah, so I'll say there are kind of two components to that. One is the impact of the vaccines on infection and transmission. And, with regard to that question, there is short-term protection against infection. We don't have good evidence yet about impact on transmission, and that's where the nasal vaccines may be more important. But that protection is relatively short-lived, over maybe a month or so, and then those antibodies will wane and that risk of infection goes back. The other question is about, the other part of the question is about hybrid immunity, and many people here in the United States and around the world have hybrid immunity. That's a combination of both vaccine-induced and infection. And there was a recent study published in the Lancet that suggested that provides pretty high protection, that combination. So the bottom line is that young, healthy people who are not at high risk, who've been vaccinated and possibly have some hybrid immunity, they're going to be pretty well protected against severe disease going forward. But that protection against infection and reducing transmission is going to be short-lived in the weeks after receiving a booster dose.
Great, thank you so much. And here's a question from Laura Ramirez Feldman at Yahoo News. Dr. Moss, you can take this, and Dr. LeMay, feel free to chime in as well. Older adults and those who are immunocompromised who received the bivalent booster when it rolled out in September are coming up on 6 months post-vaccine. Do these patients need another vaccine now to restore protection, or do they wait until the fall like everyone else?
Yes, that too. These are all great questions and not ones for which there's a straightforward answer. And so I'll just say, officially, there's not a recommendation yet for an additional booster dose for those individuals. But based on what we've been saying, I think that would be quite reasonable in vulnerable populations for whom the last booster was some time ago. There will have been some waning of protective immunity, certainly against mild and perhaps moderate disease. There's no right answer. It's also going to depend on the level of community transmission. But I would say that would be a reasonable consideration.
And Dr. LeMay?
Yeah, the only other thing I would add is that we know that age is a predictive factor for severe COVID. So just the older that an individual is, the more likely they are to unfortunately experience severe COVID. And so as Dr. Moss mentioned, I think it is really going to depend on background community transmission. But I think to Dr. Moss's point, that's why I think this recommendation that is being debated at the FDA is so critical to think about. I think having a blanket approach is a great idea for simplicity, but I think in practicality, we need to think about these specific types of populations that may require boosters at a more regular interval than those, let's say, that are younger and are healthy and are not immunocompromised. So I think it just does really illustrate the point that this really has to be a tailored response, but it has to be simple enough for people to be able to take the action that we're asking them to take as well.
Great, thank you so much. Next question is from Mindy Basara at WBAL TV for Dr. Moss. Are we any further in our understanding of long COVID?
Yes. Well, I think we are further along, and there have been a number of studies looking at, the various inflammatory and neurologic changes that underline this. But we still have a long way to go. So there has been some progress in our understanding of the pathogenesis of long COVID. I will say that long COVID is likely not a single homogeneous disease entity. So it's going to be understanding multiple different pathways to this constellation of signs and symptoms that we call long COVID. But we still have a long way to go in our understanding, and we still are far from having the therapeutic advances that we need, given the huge burden that we see here in the United States and across the world.
Great, thank you. And here's a question from Jeremy Olson at the Star Tribune for Dr. Moss and Dr. LeMay to please also comment. What is your take on the current level of safety with the COVID vaccines? Does the risk-benefit calculus still merit vaccination in all age demographic groups, or are these groups for whom any safety risks from vaccine now outweigh the benefits?
Yes, this too, a critically important question. And obviously in any situation with a vaccine, and we know that vaccines do have adverse effects and side effects associated with them, some more severe than others. It is a calculus, it is a risk-benefit ratio. both Dr. LeMay and I have pointed out that the pandemic is not over. I mentioned the more than 2,000 deaths per week here in the United States. So it's still really important that people who are unvaccinated or unboosted get vaccinated. And I think for those individuals and for the vulnerable populations that we've talked about, the risk benefit still far outweighs getting the vaccine. Where this has really come up as an issue mainly are in young, healthy adults, and particularly males, young adolescent males, in whom there is a rare risk of myocarditis or pericarditis. We know that risk is greater with COVID disease than with the vaccine. But going forward, if the risk of community transmission goes down, and those individuals have been vaccinated or have hybrid immunity or natural immunity, that maybe there will be different recommendations or a different risk benefit calculation for that group in particular.
And Dr. LeMay?
Yeah, the only thing I would add is when I usually talk to parents about, for example, childhood vaccinations, the way I think about vaccination is think about it as a car safety seat for your child, right? You're really happy that it's there. You, God forbid, hope nothing happens to your child and you don't actually have to test that car seat, but that's just one way to think about it. And as Dr. Moss mentioned, I think for most people that do have some risk factors that, could lead them to having severe COVID, I still do think that it is a recommendation that we really do want to recommend people to get a COVID vaccine, again, if there's no contraindications. I think it still does point to this idea of how do we tailor the recommendations further, again, thinking about the young males that Dr. Moss talked about, but also just thinking about all of these other types of factors that could not only lead to severe COVID, but that could also place someone at a higher risk of developing long COVID. These are all things that we need to consider. And again, there's no straight forward and easy answer, unfortunately.
Great, thank you. And here's a question for you, Dr. LeMay, from Tanaz Meghjani at Bloomberg News. Is it important to improve booster coverage among the overall population? If yes, why?
It's a really great question. One of the reasons that we have been focusing on the booster piece is, as Dr. Moss mentioned, after you receive a vaccine, your immunity wanes, right? So what that means is that you have protection for usually a limited number of time, really months, if you will. And so for the booster specifically, I think what we're interested in seeing is particularly those that are at risk. Again, those are in our older population groups, those that are immunocompromised. We would like to see those numbers increase. Those that are older have actually gotten the booster in much higher proportions than those that are younger, but there's still work to be done there. And again, as I mentioned, vaccines are one form of protection that we can take against COVID. And so to me, I still think thinking about the ways in which we can persuade those where the booster would have a pretty strong benefit for them is still really critical for us. Because again, we want to protect people from long COVID. We also want to protect people from severe COVID. And the vaccine is one way to do that.
Perfect. And we'll close with the last question for you, Dr. Moss. This is from Julia Landwehr at health.com. What might be the added benefits of new forms of COVID vaccines, such as nasal sprays? Why not just stick with traditional shots?
Yes. So I think, in many ways, we have great vaccines, but we don't have the ideal vaccine. I think the ideal vaccine would prevent against infection. It would prevent transmission. It would have more durable immunity that would last much longer, and it would be effective against multiple variants and future variants, hopefully. So all this, the research that we're seeing on COVID-19 vaccines are really trying to get us closer to that ideal vaccine. Again, recognizing we have very effective and safe vaccines currently, but we don't have the ideal vaccine. And as we mentioned earlier, one advantage of a nasal vaccine is that it can confer mucosal immunity that may actually prevent infection and thus prevent transmission.
Great. Thank you to both of you for your presentations and insightful answers. We will email the links to the resources mentioned today and shared in the chat. And with that, I'd like to say thank you again to everyone for joining us today.